The Heart, Part 2. Cardiac muscle cells are short and contain a single nucleus in the middle. The cells are cylindrical, they branch and integrate and are connected to one another by intercalated discs. Intercalated discs contain gap junctions that serve as electrical connections between the cells, and these allow transmission of action potential. Through the gap junctions, the cardiac action potential travels from the SA node to the entire cardiac muscle via the cell-to-cell conduction. The cardiac muscle works as a single unit. The intercalated discs also contain desmosomes. They are very strong mechanical connections that prevent the cells from being pulled apart during a contraction. Cardiac cells are packed with myofibrils composed of myofilaments arranged in sarcomeres. The plasma membranes or sarcolemma of the cardiac muscles includes deep T-tubules that transmit the action potential to the interior of the cell. Sarcoplasmic reticulum surrounds the myofibrils and the T-tubules and serves as the intracellular calcium store. These cells also contain myoglobulin, an oxygen-binding protein, and numerous mitochondria. Cardiac output is equal to the heart rate times the stroke volume. The average adult male may have a cardiac output of about 5 liters per minute, with a heart rate of 72 beats per minute and a stroke volume of 70 milliliters. The left ventricle never completely empties. The volume of the blood remaining after ventricular contraction is the end systolic volume. The volume of the blood in the ventricle after filling and just before contraction begins is the end diastolic volume. The stroke volume is the end diastolic volume subtracting the end systolic volume. The ejection fraction is the ratio of the stroke volume and the end systolic volume, and it is reported as a percentage of the end diastolic volume. The routine ejection fraction is 55% to 70%. The pumping action is produced by muscular contraction initiated by the heart's electrical activity and the process of excitation, contraction, coupling. The pump effectiveness is stimulated by the sympathetic nervous system and is modulated by the degree of filling, the systemic blood pressure, and the intrinsic contractility of the muscle. The myosin-actin cross-bridge formation. This is a reminder from Chapter 4. Myosin is bound to ADP and inorganic phosphate. A spike in the cell's calcium concentration facilitates calcium binding to troponin C and shifting the troponin complex and tropomyosin. This exposes the actin binding sites and the myosin head attaches to myosin. The myosin head swivels, pulling the myosin and actin in opposite directions in a move called the power stroke. Here, the ADP and the PI are released. The binding of ATP breaks the cross bridge between the myosin and the actin. The myosin head returns to its original angle splits the ATP and reattaches to an adjacent actin binding site, continuing to pull the actin strand toward the center of the sarcomere. When the calcium levels drop, tropomyosin shifts back to its original position, the myosin-actin cross bridges are released, and the muscle relaxes. The action potentials are discrete and shaped by the sodium, calcium, and potassium channels, always ending with repolarization and relaxation. The DHP receptors of the T-tubule are adjacent to the RYR of the sarcoplasm reticulum cistern. Membrane depolarization due to the muscle action potential causes the DHP to activate the RYR, and the SR releases its stored calcium. The wave of calcium quickly diffuses around the actin filaments, binding to troponin, shifting tropomyosin, and allowing myosin-actin cross bridges to form. Calcium entry through the T-tubule receptor initiates the SR calcium release. There are various steps in cardiac cell contraction. The calcium binds to troponin C and shifts the troponin, the tropomyosin complex. The myosin acting sites are exposed on the actin filaments. The actin-myosin cross bridges form. The myosin heads pivot, pulling the actin filaments in the direction that leads to cell shortening. The cycle repeats as long as the calcium is available to bind with troponin C, and adenosine triphosphate, or ATP, is available to allow the cross bridges to break and new cross bridges to form. Contraction ends when the sarcoendoplasmic reticulum calcium ATPase pumps cytoplasmic calcium back into the sarcoplasmic reticulum. In cardiac muscle, the link between action potential activity, or excitation, and contractile force development, or contraction, is known as the excitation-contraction coupling. This coupling critically depends on calcium entry via the L-type calcium channels during the plateau, or the phase 2 of the action potential. The relatively small amount of calcium entering the cell through these channels triggers a sarcoplasmic reticulum ryanodine receptor, leading to a much greater release of calcium from the sarcoplasmic reticulum. The sympathetic influences that increase contractility. The calcium entry through the L-type calcium ion channels during the plateau of the action potential initiates EC coupling. The small initial calcium and spike triggers the ryanodine receptor to release more calcium from the SR storage. The calcium is then available for actin-myosin cross-bridge formation until the action potential ends and circa pumps calcium back into the reticulum, allowing diastolic relaxation. Norepinephrine binding to beta-adrenergic receptors activates the GS, increasing intracellular C-amp and activating the pKa. The calcium entry is enhanced by phosphorylation of membrane calcium ion channels and circuit activity is increased owing to phosphorylation of phospholamban. These actions promote ionotropy and leuestrophy. Phospholamban is a protein of the sarcoplasmic reticulum membrane that regulates the rate of sarcoplasmic reticulum calcium activity, or the SERCA. When an individual is at rest with a relatively slow heart rate, phospholamban is not phosphorylated, and it inhibits the SERCA activity. As a result, when the heart rates are relatively slow, the rate of ventricular relaxation, also known as leuestropy, is moderate. This is altered when the heart is stimulated by increased sympathetic nervous system activity. End diastolic volume in the ventricle sets cardiac muscle length before the contraction, and this is preload. Afterload is the force experienced by the ventricle after contraction has started. The transition from a mostly empty ventricle to a full ventricle increases the stretch of the heart before contraction, which is preload, and results in stronger contractile activity. This is hypothesized to result from a better lineup, for a better word, of actin and myosin filaments as the heart muscle is stretched. The Frank-Starling law of the heart, or the Frank-Starling relationship, is the greater the ventricle filling, the preload, within normal limits, the closer muscle contraction strength is to its maximal potential. When plotting the stroke volume against the left ventricular end diastolic volume, is illustrated as the improved performance as the LVEDV increases for the normal heart functioning, which is the purple line. Increased contractility that could result from sympathetic stimulation will shift the curve upward, increasing the stroke volume at each level of the end diastolic volume, or the green line. A weakened heart muscle associated with heart failure cannot achieve adequate stroke volume to sustain modest physical activity at any level of preload. This is the red line. The positive ionotropic effect of sympathetic stimulation is seen at any preload, and increased sympathetic activity shifts the preload contraction strength curve in an upward direction. Summarizing the influences on cardiac heart rate, remembering that it is cardiac output, remembering that it is the heart rate times the stroke volume, both of the components are under control of the autonomic nervous system. The heart rate is decreased by parasympathetic activity and increased by sympathetic activity. The stroke volume is determined by the preload, the afterload, and the cardiac contractility. The influence of preload is illustrated in the Frank-Starling law of the heart, meaning greater filling leads to greater stroke volume. Afterload is the force of the ventricle that it must overcome to achieve ejection. Greater afterload leads to decreased stroke volume. Cardiac contractility is modulated by the sympathetic nervous system in accordance with what the body requires at rest and during physical activity. The sympathetic activity also accelerates the ventricular relaxation, allowing better filling as the heart rate increases. The heart alternates between ventricular contraction, systole, and a period of ventricular relaxation, or diastole. At a resting heart rate, systole typically lasts 1/3 of the cycle, and diastole will last 2/3. Contractile events of the heart predictably follow the electrical events of the atrial activation, the P wave, and the ventricular activation, the QRS complex. This image focuses on the left side of the heart, and these occur simultaneously on the right side of the heart. The dark shading of the chambers indicates the contractile state. Systole starts when an action potential is propagated to the ventricles, denoted by the QRS complex. After a brief period of pressure development, aortic and pulmonary valves open and the ejection begins. The T wave signifies ventricular repolarization and rapid ventricular retraction, initiating diastole. After a brief period of relaxation, the mitral and tricuspid valves open and the filling of the ventricles begins. The P wave signifies atrial depolarization, and atrial contraction provides the final volume filling the ventricle. The P wave represents atrial depolarization. It initiates the atrial contraction, which completes ventricular filling. This is the first phase of ventricular diastole. The QRS complex represents ventricular depolarization, and it initiates ventricular contraction. The first event of systole is the beginning of the ventricular contraction, which immediately generates pressure that closes the mitral valve. As both the mitral and aortic valves are now closed, this period of pressure development is referred to isovolumic contraction. On physical examination, this phase is also associated with S1 heart sound due to the closure of the mitral and tricuspid valves. As soon as ventricular pressure exceeds aortic diastolic pressure, the aortic valve opens and ejection begins. The left ventricular volume rapidly empties early in the ejection phase, even as left ventricular and aortic pressures continue to increase. Late systole is associated with reduced volume in the ventricle, so ejection slows. The T wave represents ventricular cell repolarization and the beginning of relaxation of the myocardial cells. As the left ventricular pressure falls to a level below aortic pressure, the aortic valve closes. Closure of the aortic and pulmonary valves produces the S2 heart sound. Isovolumic relaxation occurs at the beginning of diastole. The aortic valve has closed, and left ventricular pressure is still higher than left atrial pressure. So this phase of relaxation occurs without a change in left ventricular volume. Once left ventricular pressure is lower than left atrial pressure, the mitral valve opens. This phase is associated with rapid ventricular filling, and may sometimes end with a heart sound of S3, indicating rapid blood entry into an almost full ventricle. S3 may be heard as a normal variant in young athletes, but it is more likely in older adults with heart failure. The end of the passive filling phase shows little change in ventricular volume and pressure. This stage terminates with the P wave and the beginning of atrial contraction, or phase 1. In this depiction, point A, the atrial pressure exceeds that in the ventricle to open the mitral valve and permit the initial filling of the still relaxing ventricle. Point B, the ventricle is fully relaxed and fills as the atrium starts to contract. Point C is the onset of ventricular contraction when the left ventricular pressure exceeds that of the atrium and the mitral valve closes. At this point, the ventricular pressure rapidly builds, but the volume does not change, as it does not exceed the aortic pressure. For point D, the left ventricular pressure exceeds aortic pressure, and the aortic valve opens, beginning ejection. The pressure at point D corresponds to the diastolic blood pressure. Point E is the peak ventricular aortic pressure. This is systolic blood pressure is achieved as ejection systole is waning. After the ventricular contraction is maximized in point E, the pressure drops with the start of diastole. Point F, when the ventricular pressure is lowered than the aortic pressure, the aortic valve closes. The ventricular pressure then precipitously falls from point F to point A. This is due to the aortic valve and the mitral valve being both closed. The left ventricular volume cannot change until the pressure drops below that of the left atrium, with the reopening of the mitral valve again in point A. In every point in the cardiac cycle, the ventricles have a maximum volume and a maximum pressure that they can sustain. Pressure volume loops show how preload affects cardiac stroke volume and its work. In accordance with Frank-Starling mechanism, increased preload increases the stroke volume. The increased preload also increases cardiac work and metabolic demand. In contrast, the increases in peak systolic pressure are relatively conservative. Afterload increases as arterial pressure increases. The ventricle must work harder to overcome high diastolic pressure to open the aortic valve, and must continue to have a stronger contraction to eject the volume against the rapidly rising systolic pressure. These factors will result in decreased volume, but an equal amount of cardiac work. As the aortic pressure increases, the stroke volume decreases. The cross-sectional areas within the loops are minimally affected by increased afterload. This depicts how cardiac work is unaffected by increased afterload, but it can reduce cardiac output. Vasodilators, which decrease afterload, will increase the cardiac output with minimal effects on the cardiac work. This slide is information related to summary of the heart pumping function. The cardiac vessels consist of the coronary arteries, veins, and lymphatics. Oxygen and nutrients are delivered to the heart muscle by a left and right coronary artery. The metabolic demand of the heart varies with the cardiac work. Sympathetic discharge increases the heart rate and cardiac contractility, which will then increase myocardial oxygen demand. Any condition that increases cardiac work, like increased preload, afterload, or contractility, will also increase the oxygen demand of the heart. Oxygen delivery requires adequate pulmonary function to oxygenate the blood and clear carbon dioxide, as well as adequate blood flow. Coronary blood flow has a peak flow during diastole. Blood flow to the left ventricle is higher than that to the right ventricle. During systole, the cardiac muscle contracts and compresses the coronary vasculature, increasing its resistance and limiting blood flow. At diastole, coronary blood flow increases depending on aortic pressure. As the aortic pressure drops during diastole, the ventricles are relaxing and relieving the coronary vessels from compression. Coronary blood flow is maximal during diastole, but relaxed during systole. Duration of diastole affects the total myocardial blood flow. Diastole during a resting heart rate of 70 beats per minute is about 2/3 of a cardiac cycle. As the heart rate increases, the duration of diastole shortens, with the duration of systole remaining relatively constant. The shortening of diastole is paralleled by a shortened period of coronary blood flow, reducing blood and oxygen supply just as tissue oxygen demands are increasing because of the faster heart rates. Coronary blood flow also undergoes autoregulation. This intrinsic property of the heart adjusts coronary vasculature resistance to maintain coronary blood flow despite the changes in the perfusion pressure from 60 to 140 millimeters of mercury. In addition, local endothelial and vascular factors contribute to the regulation of coronary blood flow. The right coronary artery supplies the entire right ventricle, the inferior and posterior side of the left ventricle, and the posterior 1/3 of the interventricular septum. It also provides the blood to the AV. The left coronary artery, also known as the left main artery, branches. It gives rise to the left anterior descending and the left circumflex arteries. The left anterior descending artery provides blood to the anterior wall of the left ventricle, the apex of the heart, and the interior 2/3 of the interventricular septum. The left circumflex artery provides the blood for the lateral and posterior walls of the left ventricle. The muscle fibers of the inner wall of the endocardium are supplied by terminal branches of the coronary arteries or from thespian veins that tunnel directly from the ventricular cavity. When a coronary artery is obstructed, these vessels may dilate to deliver blood from healthy collateral vessels to adjacent regions that are affected by ischemia. Coronary blood flow is pulsatile, but has a peak flow during diastole. This seemingly contrary pattern is due to the unique anatomy of the coronary vasculature. During systole, the cardiac muscle contracts and compresses the coronary vasculature, increasing its local resistance and limiting blood flow. Coronary artery disease resulting in an MI is the most common cause of death. When cardiac oxygen demand is not met by the oxygen supply, the resulting cardiac ischemia can produce symptoms of angina. These are angina symptoms that the patient will complain about. The earliest phases of coronary heart disease, exercise, or physical demanding activities can promote angina symptoms that resolve shortly after stopping the activity. This type of angina is known as exertional angina, but it can also be referred to as stable angina. This can be an early indication of developing atherosclerotic plaque in the coronary vasculature, and it may show some improvement using a vasodilator like nitroglycerin, because nitroglycerin relaxes the smooth muscle in the walls of the veins, increasing blood pooling in these capitance vessels, which reduces the preload and the work of the heart. Stable angina can increase in severity and can take longer to resolve. The pain may occur more often with elevated intensity and accompanied by labored breathing, and it can progress to a state where it does not follow a predictable pattern. This can arise without physical exertion and may not be alleviated by medication. This is now termed unstable angina, and it indicates deterioration of coronary artery blood flow and should be regarded as an emergency. Variant angina or Prinzmetal angina is a less common condition that does not begin during exertion, but characteristically occurs while resting, during the night, or during early morning hours. Pain and nausea can be severe and are not alleviated by rest. Variant angina is triggered by coronary vasospasms. This can be treated using vasodilators like nitroglycerin. However, coronary arterial vasospasms are thought to be the primary event associated with triggering sudden cardiac death. Coronary atherosclerosis often progresses along a spectrum from stable angina to unstable angina as the coronary blood flow is reduced. The rupture of an atherosclerotic plaque's fibrous cap can promote immediate formation of a thrombus that acutely obstructs coronary blood flow. A partial obstruction may promote unstable angina or a non-ST elevation MI with intermittent chronic tissue damage. Complete obstruction of a coronary vessel may produce the NSTEMI, or it may rapidly destroy a greater volume of cardiac tissue, resulting in myocardial necrosis, and a full thickness cardiac wall damage. This will present as an ST elevation myocardial infarction or a STEMI. Reduced coronary artery blood flow decreases the delivery of oxygen-rich blood to the cardiomyocytes. Impaired blood flow and delivery produces the highest level of ischemia in the subendocardium and may result in alterations of the ST segment in an EKG in the form of a depression of the ST segment or as an inverted T wave. The NSTEMI has the characteristic elevations in blood levels of troponins and other markers of cardiac cell death, indicating that an infarction has occurred. Pre-existing atherosclerosis or other acute factors like hypotension, inflammation, prothrombic states can result in a STEMI. The rupture of an atherosclerotic plaque releases thrombogenic substances, rapidly precipitating the formation of a clot that may completely occlude the narrow vessel, leading almost immediately to profound tissue hypoxia and ischemia. The cardiomyocyte death will fully extend through the vascular wall as a transmural infarction and causes a full-blown heart attack. The massive damage to cardiomyocytes causes a blank region of conduction that shifts the resting membrane, and this shift is responsible for the observation of an elevated ST segment and causes release of cardiac cellular enzymes and proteins, and this is known as a STEMI. Troponins are regulatory proteins in the thin filaments that are integral to cardiac myocyte contraction. Levels of both cardiac-specific troponin 1 and troponin T can be detected 6 to 12 hours after the onset of myocardial injury, peaking at about 24 hours. Creatinine phosphokinase can also be released by the damage. EKG changes associated with STEMIs can evolve when and if the tissue damage resolves. The damaged section of the wall is unable to conduct depolarizations, but a downward reflected Q wave appears, remaining as a permanent marker of the coronary infarction. Women are more likely overall to report angina, but they are less likely to have exertional pain and more likely to report emotional stress-induced pain and persistent angina, as well as having pain at rest. Angina is associated with decreased quality of life. Women are less likely to report any chest pain and have higher rates of undetected myocardial infarction. Associated symptoms for women may include pain in the back, neck, and jaw, shortness of breath, nausea or indigestion, and fatigue. The coronary arteries travel along the surface of the epicardium, giving off branches that go to 3 different depths before branching into smaller arteries, arterioles, and capillaries. The large epicardial arteries represent less than 10% of the vascular resistance. Small arteries represent approximately 20% of the vascular resistance, and large arterioles represent 50% of the vascular resistance. The smallest arterioles are regulated by the local metabolism. Coronary microvasculature dysfunction is the term used to describe vascular compromise that results in myocardial ischemia in the absence of significant lesions in the large coronary arteries.